Chapter 36, Introduction to the Nervous System, Med-Surg, TIMBY. Learning Objectives. Name the 2 anatomic divisions of the nervous system. Name the 3 parts of the brain. List the 4 lobes of the cerebrum. Give 2 functions of the spinal cord. Name and describe the function of the 2 parts of the autonomic nervous system. Describe the methods used to assess motor and sensory function. List 6 diagnostic procedures performed to detect neurologic disorders. Discuss the nursing management of the client undergoing neurologic diagnostic testing. Nervous system anatomy and physiology. The nervous system consists of the brain, spinal cord, and peripheral nerves. It is responsible for coordinating body functions and responding to changes in or stimuli from the internal and external environment. Changes in the functioning of the nervous system can profoundly affect the entire body. Anatomy and physiology. The nervous system is divided into 2 anatomic divisions, the central nervous system, CNS, and the peripheral nervous system, PNS. The basic structure of the nervous system is the nerve cell, or neuron. Neurons are either sensory or motor. Sensory neurons transmit impulses to the CNS, and motor neurons transmit impulses from the CNS. A neuron is composed of a cell body, a nucleus, and thread-like projections or fibers called dendrites and axons. Dendrites conduct impulses to the cell body and are called afferent, to or toward nerve fibers. Axons are nerve fibers that project and conduct impulses away from the cell body. They are therefore called efferent, E-F-F-E-R-E-N-T, away from nerve fibers. An axon is usually larger than the dendrites. Neurons are separate units and not directly connected to one another. Impulses travel along the neurons, moving from one neuron to another by means of synapses. That is, junctions between the axon of one neuron and the dendrite of another. Substances called neurotransmitters or neurohormones accomplish the transmission of an impulse from one neuron to another. Neurotransmitters can either excite or inhibit neurons. A fatty substance called myelin covers some axons in the CNS and PNS. A membranous sheath called the neurolema covers the myelin of axons in peripheral nerves. Axons that are covered by myelin are called myelinated white matter or white nerve fibers. Axons that are not covered with myelin are called unmyelinated gray matter or gray nerve fibers. Myelin serves as an insulating substance for the axon that confines the electrical conduction without allowing it to scatter. However, myelinated nerves are segmented with periodic gaps called the nodes of Ranvier. When impulses travel along the axons of myelinated nerves, they leap from node to node, a process called saltatory conduction, which is much faster than impulses traveling along the axons of unmyelinated nerves. The central nervous system. The central nervous system consists of the brain and the spinal cord. The brain. The brain is divided into 3 parts, the cerebrum, the cerebellum, and the brain stem. The cerebrum consists of 2 hemispheres connected by the corpus callosum, a band of white fibers that acts as a bridge for transmitting impulses between the left and right hemispheres. Each hemisphere has 4 lobes: frontal, parietal, temporal, and occipital. The cerebral cortex is the surface of the cerebrum. It contains motor neurons, which are responsible for movement, and sensory neurons, which receive impulses from peripheral sensory neurons located throughout the body. Motor tracts are parietal or extraparietal. Parietal motor pathways originate in the motor cortex of the cerebrum. They cross over at the level of the medulla and end in the brainstem and spinal cord. Extraparietal fibers originate in the motor cortex and project to the cerebellum and basal ganglia. They do not cross over because they connect to motor neurons in the spinal cord. The cerebellum, which is located behind and below the cerebrum, controls and coordinates muscle movement. The brain stem consists of the midbrain, pons, and medulla oblongata. The midbrain connects the pons and the cerebellum within the 2 cerebral hemispheres. The pons is located between the midbrain and medulla and connects the two hemispheres of the cerebellum with the brainstem, spinal cord, and cerebrum. The medulla oblongata lies below the pons and transmits motor impulses from the brain to the spinal cord and sensory impulses from peripheral sensory neurons to the brain. The medulla contains vital centers concerned with respiration, heartbeat, and vasomotor activity, which is the control of smooth muscle activity in blood vessel walls. The brain is protected by the rigid bones of the skull and is covered by three membranes or meninges. One, the dura mater, the tough outermost covering. Two, the arachnoid or middle membrane lying directly below the dura mater. And three, the pia mater, a delicate layer that adheres to the brain and spinal cord. The subarachnoid space lies between the pia mater and the arachnoid membrane. Within the brain, there are four cavities called ventricles, two lateral ventricles, the third ventricle, and fourth ventricle. The ventricles manufacture cerebrospinal fluid, CSF, from tissue fluid within the choroid plexus that lines the ventricles. CSF protects the structures of the brain like a shock absorber, acts as a barrier to infectious organisms, toxic metabolites, and some drugs that enter the blood, floats the brain to reduce pressure at its base, and helps maintain relatively constant intracranial pressure. Once CSF is formed, it is circulated within the subarachnoid space of the brain and spinal cord to openings where it becomes reabsorbed into the venous system. In review, the cerebrum consists of two hemispheres connected by the corpus callosum, a band of white fibers that acts as a bridge for transmitting impulses between the left and right hemispheres. Each hemisphere has four lobes: frontal, parietal, temporal, and occipital. The cerebral cortex is the surface of the cerebrum. It contains motor neurons, which are responsible for movement, and sensory neurons, which receive impulses from peripheral sensory neurons located throughout the body. Motor tracts are parietal or extraparietal. Parietal motor pathways originate in the motor cortex of the cerebrum, cross over at the level of the medulla, and end in the brain stem and spinal cord. Extraparietal fibers originate in the motor cortex and project to the cerebellum and basal ganglia. They do not cross over because they connect to motor neurons in the spinal cord. The cerebellum, which is located behind and below the cerebrum, controls and coordinates muscle movement. The brainstem consists of the midbrain, pons, and medulla oblongata. The midbrain connects the pons and cerebellum within the two cerebral hemispheres. The pons is located between the midbrain and medulla and connects the two hemispheres of the cerebellum with the brainstem, spinal cord, and cerebrum. The medulla oblongata lies below the pons and transmits motor impulses from the brain to the spinal cord and sensory impulses from peripheral sensory neurons to the brain. The medulla contains vital centers concerned with respiration, heartbeat, and vasomotor activity, which is the control of smooth muscle activity in blood vessel walls. The brain is protected by the skull. The brain is protected by the rigid bones of the skull and is covered by three membranes. One, the dura mater, the tough outermost covering. Two, the arachnoid or middle membrane lying directly below the dura mater. And three, the pia mater, a delicate layer that adheres to the brain and spinal cord. The subarachnoid space lies between the pia mater and the arachnoid membrane. Within the brain, there are four cavities called ventricles. Two lateral ventricles, the third ventricle, and the fourth ventricle. The ventricles manufacture cerebrospinal fluid, called CSF, from tissue fluid within the choroid plexus that line the ventricles. CSF protects the structures of the brain like a shock absorber, acts as a barrier to infectious organisms, toxic metabolites, and some drugs that enter the blood, floats the brain to reduce pressure at its base, and helps maintain relatively constant intracranial pressure. Once CSF is formed, it is circulated within the subarachnoid space of the brain and spinal cord to openings where it becomes reabsorbed into the venous system. Question: which part of the brain controls breathing? The medulla, the cerebellum, the cerebrum, or the thalamus? Your answer should be the medulla. The medulla oblongata transmits motor impulses from the brain to the spinal cord and sensory impulses from the peripheral sensory neurons to the brain. The medulla contains vital centers concerned with respiration, heartbeat, and vasomotor activity, which is the smooth muscle lining of the vascular system. The spinal cord. The spinal cord, which is covered by the meninges, is a direct continuation of the medulla and is surrounded and protected by the vertebrae, or vertebral column. The spinal cord ends between the first and second lumbar vertebrae, where it divides into smaller sections called the cauda equina. The spinal cord functions as a passageway for ascending sensory and descending motor neurons. Its two main functions are to provide centers for reflex action and to serve as a pathway for impulses to and from the brain. The sensory fibers enter the posterior or dorsal portion of the cord, while the nerve fibers that transmit motor impulses run outward to the peripheral nerves from the anterior or ventral portion of the cord. Peripheral nervous system. The peripheral nervous system consists of all the sensory and motor nerves outside the CNS. The peripheral nervous system includes the cranial, spinal, and sympathetic and parasympathetic nerves of the autonomic nervous system, ANS. Cranial nerves. The 12 pairs of cranial nerves identified by Roman numerals are as follows. 1. Olfactory nerve, the sense of smell. 2. Optic nerve, sight. 3. Oculomotor nerve, contraction of the iris and eye muscles. 4. Trochlear nerve, eye movement. 5. Trigeminal nerve, sensory nerve to the face, chewing. 6. Abducens nerve, eye movement. 7. Facial nerve, facial expression, taste, secretions of salivary and lacrimal glands. 8. Vestibulocochlear or auditory nerve, hearing and balance. 9. Glossopharyngeal nerve, taste, sensory fibers of pharynx and tongue, swallowing, and secretions of parotid gland. 10. Vagus nerve, motor fibers to glands produce digestive enzymes, heart rate, muscles of speech, gastrointestinal motility, respiration, swallowing, coughing, and vomiting reflex. 11. Accessory or spinal accessory nerve, head and shoulder movement. 12. Hypoglossal nerve, which is movement of the tongue. Spinal nerves. There are 31 pairs of spinal nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Spinal nerves have 2 roots, dorsal and ventral. Dorsal nerve fibers are sensory and ventral nerve fibers are motor. Peripheral sensory nerve fibers in various areas of the body transmit impulses to the spinal nerves, which transmit impulses up the spinal cord to the brain. Motor impulses traveling from the brain and down the spinal cord leave by the ventral root and travel to areas of the body. Each spinal nerve root innervates a specific area or dermatome of the body surface. Knowledge of the distribution of dermatomes is helpful for identifying areas affected by certain viral infections such as shingles, anesthetizing localized areas of the body, and assessing and evaluating spinal injuries. Autonomic nervous system. The autonomic nervous system consists of the sympathetic nervous system and the parasympathetic nervous system. It facilitates functions essential to survival. The two divisions of the ANS generally function antagonistically to each other. They maintain homeostasis by stimulating or inhibiting smooth muscles, cardiac muscle, and glands. Sympathetic nervous system. The sympathetic nervous system is the division of the ANS that responds using a fight or flight response when there is a perceived or actual threat to survival. The neurotransmitters of the sympathetic nervous system, collectively known as catecholamines, are epinephrine, norepinephrine, and dopamine. The adrenal medulla produces and secretes epinephrine and norepinephrine. Norepinephrine is also produced at sympathetic nerve endings. Dopamine is a precursor, a substance that precedes another, of norepinephrine. Norepinephrine then becomes epinephrine. Stressful situations such as danger, intense emotion, and severe illness result in the release of catecholamines. Parasympathetic nervous system. The parasympathetic nervous system is the division of the ANS that works to conserve body energy and is partly responsible for slowing heart rate, digesting food, and eliminating body waste. Acetylcholine is a neurotransmitter released at the nerve endings of parasympathetic nerve fibers, at some nerve endings in the sympathetic nervous system, and at nerve endings of skeletal muscle. Release of this neurotransmitter allows passage of a nerve impulse from the nerve fiber to the effector organ or structure, where the enzyme acetylcholinesterase inactivates acetylcholine. Question: which of the following responses indicates sympathetic nervous system activation? Tachycardia and dilated pupils, increased peristalsis, abdominal cramping, hypoglycemia and headache, pupil constriction and bronchoconstriction. Your answer should be tachycardia and dilated pupils. The autonomic nervous system regulates the expenditure of energy and secretes epinephrine and norepinephrine. If you look on page 606, there's a nice chart on the autonomic effects of the nervous system for sympathetic, when stimulated, sympathetic effects, and when parasympathetic effects are stimulated, what it does to the pupils, the circulatory system, the respiratory system, the digestive system, and the GU system. You definitely need to memorize these. Also, muscles of the uterus, blood vessels of external genitalia, and skin, sweat, and pilomotor muscles, and the adrenal medullae, which is secretion of epinephrine and norepinephrine. Assessment. A neurological assessment is performed to identify and locate disorders of the nervous system. The scope and extent of the neurologic examination often depends on the symptoms and the probable or actual diagnosis. The use of opioids or CNS depressants can affect the results of a neurological assessment. Client assessment and history taking may be temporarily delayed until an opioid is metabolized. History. A thorough history is essential. The nurse explores all symptoms and asks questions to clarify each symptom. The history must include a record of trauma, no matter how slight, to the head or body within the past 6 to 12 months, a drug history, an allergy history, and a family medical history. The nurse observes the client's speech pattern, mental status, intellectual functioning, reasoning ability, strength, and movement or lack thereof in all extremities. When taking the health history of an older adult who has difficulty remembering recent or past events, symptoms, drug and medical history, and any other necessary facts, obtain or confirm the information with a family member or friend. Physical examination. The physical examination consists of assessment of the cerebral, motor, and sensory activities. The nurse usually assesses a client's intellectual function and speech pattern during the history by noting responses to questions. Additional testing of intellectual function includes asking various questions that require mental tasks. See discussion of mini mental status examination, chapter 67. The nurse evaluates the client's body posture and any abnormal position of the head, neck, trunk, or extremities. If head trauma has occurred, the nurse examines the ears and nose for evidence of bleeding or other drainage, such as CSF. He or she carefully examines the head for bleeding, swelling, or wounds. The nurse does not move or manipulate the client's head during this part of the assessment, especially if there is a recent history of trauma. Cranial nerves. The experienced examiner evaluates all or some of the 12 cranial nerves, table 36.2. Motor function. Assessment of motor function includes muscle movement, size, tone, strength, and coordination. The nurse inspects large muscle areas for evidence of atrophy and assesses opposing muscles for equality of size and strength. He or she asks the client to perform tasks such as pushing the palm or sole against the examiner's palm. picking up small and large objects between the thumb and forefinger, grasping objects firmly, resisting removal of an object from the fist or fingers. To assess gait, movement, and balance, the nurse asks the client to walk away from the examiner, turn, and walk back. Other tests include climbing a set of stairs, walking and turning abruptly, and walking heel to toe. In the Romberg test, the client stands with feet close together and eyes closed. If the client sways as if to fall, this is considered a positive Romberg test, indicating a problem with equilibrium. The examiner stands fairly close to the client during this test in case the client loses balance. Tests that evaluate motor and cerebral function include doing the finger-to-nose test with eyes closed, writing words, and identifying common objects. The choice of tests depends on the original problem and the findings of diagnostic tests. The nurse evaluates motor response in the comatose or unconscious patient by administering a painful stimulus to determine the client's response. An appropriate response is for the client to reach toward or withdraw from the stimulus. Clients with impaired cerebral function manifest abnormal posturing. Decorticate posturing, decorticate rigidity, is a position in which the arms are flexed, fists are clenched, and the legs are extended. You can see this on page 609 on figure 36.7, and this is A. We're talking about decorticate posturing. Decerebrate posturing is decerebrate rigidity, is when the extremities are stiff and rigid. Decerebrate posturing is more serious than decorticate posturing. Even more ominous is flaccidity, when the client makes no motor response. Cranial nerves. Cranial nerve 1, olfactory. Ask the client to block each nostril separately and close the eyes. Present familiar odors such as vinegar, lemon, coffee, and ammonia. Normal findings: the client identifies the odors correctly. Cranial nerve 2, optic. Help client cover each eye separately. Test visual acuity using a Snellen chart, newspaper, or Jaeger chart. Client names letters or reads words accurately. Client and examiner cover an eye, and examiner moves an object from the periphery towards client's nose from superior, inferior, medial, and lateral positions while both fix their gaze straight ahead. Examiner then tests opposite eye. Inspect optic nerve with an ophthalmoscope. Normal findings are the client and examiner see object at the same time in the visual field, and the optic nerve appears round and lighter than surrounding retina. Cranial nerve 3, oculomotor. In a darkened room, shine a bright light in each pupil. Ask the client to look at a near and far object. Normal response is the pupil constricts briskly in response to light and dilates when looking far away. Ask client to follow an object you move in horizontal, vertical, and oblique directions. Eye movement is coordinated in all directions. Trochlear. Cranial nerve 4. See the assessment for motor function of oculomotor nerve. The eyes should move inferiorly and medially. Cranial nerve 5, trigeminal. Observe for jaw symmetry while client opens mouth. Instruct client to clamp jaws tightly together. The appearance is symmetric. The muscles contract bilaterally. Stroke the forehead, jaws, and cheeks with a wisp of cotton, a sharp object like a pin, a cold and warm object, and a vibrating tuning fork. The client shows bilateral sensitivity and correctly identifies sensory experience. Touch each cornea with a wisp of cotton. Client blinks. Tap center of chin with a reflex hammer while client slightly opens the mouth. Jaw closes suddenly and slightly. Cranial nerve 6, abducens. See assessment for motor function of oculomotor nerve, and the client should move the eyes in lateral directions. Cranial nerve 7, facial. Ask client to wrinkle the forehead, smile, frown, raise eyebrows, look at ceiling, and whistle. Facial movements are symmetrical. Instruct the client to close eyelids and resist examiner's efforts to open them. Both eyes equally resist efforts to open them. Apply sweet, sour, salty, and bitter flavors to both sides of the anterior tongue. The client accurately identifies taste. Cranial nerve 8, vestibulocochlear. Test hearing acuity and perform the Rhine and Weber test with a tuning fork. See Chapter 43. The client repeats whispered words correctly. Sound is lateralized equally and heard longer by air than by bone. Have the client stand with both feet together. Note for swaying with eyes open and then shut. The client should maintain balance or sway very slightly. Glossopharyngeal nerve. This is nerve 11 9. Touch palate with a tongue blade. This blade should elicit a gag response. Ask client to say ah. Uvula remains midline. Have client say la la la. Client speaks clearly and distinctly with no hoarseness. Vagus nerve. This is the vagus nerve. Have client say la la la. The client speaks clearly and distinctly with no hoarseness. Spinal nerve. Spinal accessory nerve 11. Instruct client to shrug the shoulders as you apply resistance, and the client normally raises the shoulders against. Cranial nerve 12, hypoglossal. Tell the client to stick out the tongue. The tongue remains in midline with no lateral deviation. In review, impaired cerebral function is indicated by posturing. Decorticate, this is in an unconscious patient. Decorticate posturing is arms flexed, fists clenched, and legs extended in picture A. In picture B, decerebrate posturing, stiff and rigid extremities. And flaccidity is no motor response. Being flaccid has no response, and that's the worst case scenario. Sensory function. The nurse evaluates the extremities for sensitivity to heat, cold, touch, and pain. He or she can use various objects such as cotton balls, tubes filled with hot or cold water, and sharp objects that do not pierce the skin to check sensation in the extremities. Level of consciousness. Depending on the client's symptoms, evaluation of the level of consciousness, called LOC, is often necessary. The following classification of LOC applies to altered consciousness from any cause. Differentiating between each level can be difficult. Some clients may show characteristics of 2 or more levels. Conscious, the client responds immediately, fully, and appropriately to visual, auditory, and other stimulation. Somnolent or lethargic, the client is drowsy or sleepy at inappropriate times but can be aroused only to fall asleep again. Responses to questions and verbal commands are delayed or inappropriate. Speech is incoherent. Painful stimuli elicit a response. Stuporous, the client is aroused only by vigorous and repetitive physical, auditory, or visual stimulation. Stimulation results in 1 or 2 word answers or in motor activity or purposeful behavior directed toward avoiding further stimulation. Semi-comatose. The client is unresponsive except to superficial, relatively mild painful stimuli to which the client makes some purposeful motor response or movement to avoid further stimulation. Spontaneous motion is uncommon, but the client may groan or mutter. Comatose. The client responds only to very painful stimuli by fragmentary, delayed reflex withdrawal. In deeper stages, he or she loses all responsiveness. There is no spontaneous movement and the respiratory rate is irregular. Gerontologic considerations. The possibility of drug toxicity or abrupt onset of delirium should always be considered when an older person has a change in mental status. The aging brain may develop various compensatory mechanisms. Mental exercises can help to retain vocabulary, special awareness, and problem solving. Physical exercise promotes circulation, and involvement in social or educational activities can help retain function. The nurse assesses LOC at frequent intervals after injury to the head or neck, cranial surgery, a cerebrovascular accident in the acute phase, a ruptured cerebral aneurysm, and other neurologic disorders. He or she makes his assessment hourly unless the physician orders otherwise or a change occurs in the client's condition. Glasgow Coma Scale. The Glasgow Coma Scale, box 36-1, page 610, is an objective assessment tool for evaluating LOC of a client. The scale consists of 3 parts: eye-opening response, best verbal response, and best motor response. To evaluate responses correctly, several verbal and motor responses are elicited and the best response is recorded. The eye-opening response is determined by talking to the client and calling out his or her name. If no response is noted, in other words, the eyes do not open spontaneously, a painful stimulus is applied and the response is noted. The verbal response is evaluated by a verbal reply to questions. The motor response is the ability of the client to follow commands, such as wiggle your toes or move your left hand. If there is no response, a painful stimulus is used and the response is noted. The responses are assigned numbers and the numbers are totaled. A normal response is 15. A score of 7 or less is considered coma. The evaluations are recorded on a flow sheet to quickly evaluate an increase or decrease in the LOC. Also see Evidence-Based Practice 36.1. Rancho Los Amigos Scale. The Rancho Los Amigos Scale, box 36.2, is another tool for assessing LOC. Some rehab centers prefer this scale because it is a more flexible assessment tool for identifying variations in the client's status. Box 36.2, the Rancho Los Amigos Scale. Level 1, no response to stimuli, appears in deep sleep. Level 2, generalized response. First reaction may be to deep pain, has delayed inconsistent responses. Level 3, localized response. Inconsistent responses, but reacts in a more specific manner to stimulus, might follow simple command, squeeze my hand. Level 4, confused, agitated. Reacts to his own inner confusion, fear, disorientation, excitable behavior, and may be abusive. Level 5, non-agitated, confused, inappropriate. Usually disoriented, follows tasks for 2 to 3 minutes, but easily distracted by environment and frustrated. Level 6, confused, appropriate, follows simple directions consistently, memory and attention increasing, self-care tasks performed without help. Level 7, automatic, appropriate. If physically able, can carry out routine activities, appears normal, needs supervision for safety. Level 8, purposeful, alert, oriented, may have decreased abilities relative to premorbid state. Pupils. The size and equality of the pupils and the reaction to light are an assessment of the third cranial oculomotor nerve. See Table 36.2. Pupil size, normal, pinpoint, dilated. Equality, equal, unequal in size, and reaction to a bright light, normal, sluggish, no reaction, fixed, are noted. When the pupils are examined, any abnormal movement or position of one or both eyes is noted. Unequal pupils, one pupil larger than the other, dilated or pinpoint pupils, and failure of the pupils to respond quickly to light are in most instances abnormal findings. Any sudden change in pupil size, equality, or reaction to light is an important neurologic finding and is reported to the physician at once. Opioids use will cause the pupils to constrict and become pinpoint. They will remain as such and do not dilate in low-level light. The drug, not a neurologic disorder, causes the alteration. Pupillary response is more sluggish in older adults. When cataracts are present, there may be no pupillary response. Neck. The neck is examined for stiffness or abnormal position. The presence of rigidity is checked by moving the head and chin towards the chest. This should never be done if a head or neck injury is suspected or known or trauma to any part of the body is evident. Range of motion of the neck may be affected in older adults because of arthritic changes. Vital signs. The blood pressure, pulse, and respiratory rates and temperature are closely monitored on all clients with potential or actual neurologic disorder. The temperature often needs to be monitored every hour because CNS disorders can affect the temperature regulating ability of the hypothalamus. A sudden increase or decrease in any of the vital signs indicates a change in the neurologic status, and the physician is notified immediately. Diagnostic tests. Imaging procedures. Imaging procedures such as CT, computed tomography, magnetic resonance imaging, MRI, positron emission tomography, PET, and single photon emission computed tomography, which is SPECT, are used in the diagnosis of neurologic disorders. Imaging procedures are particularly useful in the diagnosis of neurologic disorders such as brain tumors, Alzheimer's disease, intracranial bleeding, or hemorrhage and cerebral infections. Computed tomography. CT uses X-rays and computer analysis to produce three-dimensional views of thin cross-sections or slices of the body. A narrow X-ray beam rotates around the client and a computer analyzes the results. CT is extremely sensitive to differences in tissue densities, allowing differentiation between intracranial tumors, cysts, edema, and hemorrhage. The client is exposed to the same amount of radiation as in a conventional X-ray. A radiopaque dye may be used during CT scan to emphasize or highlight a certain area. Use of a radiopaque dye decreases the safety of the procedure, primarily owing to the risk of an allergic reaction. Clients who are allergic to iodine should not receive radiopaque dyes that contain this substance. Seafood allergies suggest an allergy to iodine. A thorough allergic history is essential assessment prior to a neurologic examination involving contrast media. Magnetic resonance imaging. An MRI scan is based on the magnetic behavior of protons in body tissue. MRI uses radio frequency waves to produce images of tissues of high fat and high water content, such as soft tissue, veins, arteries, the brain, and spinal cord. Images are produced without contrast dye or radiation. The client's whole body or particular body part is imaged within a tunnel or under an open, non-tunneled machine containing a powerful magnet. Open MRIs are used for those who are anxious, claustrophobic, or obese. The MRI lasts for 15 to 90 minutes. Sedation is an option for those who cannot tolerate the length of the procedure or the feeling of being enclosed. A call button and an intercom are available for two-way communication. Clients should be pre-screened for any internal device that contains magnetic metals such as cardiac pacemaker, implanted defibrillator, aneurysm clips, and the like, which may contraindicate using an MRI because metal interferes with the magnetic field. Clients with orthopedic metal implants can undergo an MRI because most are made of non-ferromagnetic materials such as titanium, stainless steel, and ceramics. Positron emission tomography, PET, uses radioactive substances to examine metabolic activity of body structures. The client either inhales or is injected with a radioactive substance with positively charged particles that combine with negatively charged particles found normally in the body. The energy emitted when these combine is converted into color-coded images, indicating metabolic activity of the organ involved. The radioactive substances are short-lived, resulting in minimal radiation exposure. PET is used less frequently than CT or MRI because the equipment is usually available only in major medical centers. Single photon emission computed tomography, SPECT, S-P-E-C-T, is a non-invasive imaging tool with the advantage of providing information about the brain's function, whereas CT and MRI only image anatomic structures. SPECT provides information about the brain's cerebral blood flow and the status of receptors for neurotransmitters. It also identifies lesions before they are visible with other imaging techniques. Data from SPECT locate the site causing epileptic seizures, help diagnose Alzheimer's and Parkinson's disease, and detect brain tumors and changes in blood flow that predict the potential or actual area of a stroke and offer prognosis for recovery. SPECT contains images of the brain after the client intravenously receives radiopharmaceuticals and radioisotopes approximately 1 hour before the test begins. Once the radioactive substances circulate, there is a scan of the brain. Colored cross-sections of the brain images are evaluated for evidence of pathology. A potential risk of SPECT is the client's allergic reaction to the imaging material. Lumbar puncture. Changes in CSF, cerebrospinal fluid, occur in many neurologic disorders. A lumbar puncture, also called a spinal tap, is performed to obtain samples of CSF from the subarachnoid space for laboratory examination and to measure CSF pressure. Bacteriologic tests on specimens of CSF reveal the presence of pathogenic microorganisms. Strict aseptic technique is required during the procedure. The CSF is normally clear and colorless with a pressure of 80 to 180 millimeters water. A pressure over 200 millimeters water is considered abnormal. A lumbar puncture also is performed before injecting a drug into the subarachnoid space, called intrathecal injection, to administer a spinal anesthetic, to withdraw CSF for the relief of intracranial pressure, or to inject air, gas, or dye for a neurologic diagnostic procedure. Approximately 10 to 20% of clients experience a post-procedural headache when assuming a supine position and head movement within 24 hours and up to 14 days after a lumbar puncture. Clients are advised to recline less than an hour up to several hours after the test, increase their fluid intake, particularly those containing caffeine, and limit their activity for 24 hours when returning home. However, some believe that these measures are minimally prophylactic because the current belief is that the headache is caused by gravitational traction on pain-sensitive intracranial structures secondary to a decreased volume of CSF or cerebral vasodilation. In severe cases, the client's discomfort may be managed by performing a blood patch, the installation of 20 to 30 mLs of the client's venous blood into the epidural space to seal the leak of CSF from the diagnostic perforation, or by instilling a similar amount of saline. Parenteral administration of caffeine, sodium benzoate, or Imitrex also may offset cerebral vasodilation. Sometimes a cisternal puncture is performed to remove CSF. The back of the head is shaved, the skin is washed with an antiseptic, and a needle is inserted just below the occipital bone of the skull. This procedure is performed more commonly on children. Headache appears to occur less frequently with cisternal puncture than with lumbar puncture. Contrast studies. Cerebral angiography. Contrast studies include cerebral angiography, which detects distortion of cerebral arteries and veins, indicating an aneurysm, a tumor, or other vascular abnormality. A radiopaque dye is injected into the right or left carotid artery, the brachial artery, or the femoral artery. A rapid sequence of radiographs is taken because the dye circulates through the cerebral arteries and veins. Myelogram. For a myelogram, a radiopaque substance is injected into the spinal canal by means of a lumbar puncture. Radiographs are taken to demonstrate abnormalities of the spinal canal, such as tumors or a ruptured intravertebral disc. Electroencephalogram, called EEG, records the electrical impulses generated by the brain. Up to 25 electrodes are attached to the scalp with a type of skin adhesive, and electrical activity is recorded on a graph. Techniques such as rapid breathing or looking at a flashing light known as photic, PHOTIC, stimulation can induce a seizure during the EEG. In some cases, the physician may request that the client be deprived of sleep before an EEG. Sleep deprivation helps the client fall asleep naturally during the EEG. The electrical activity during sleep provides additional diagnostic information. The nurse is responsible for preparing the client for the EEG as follows. Tell the client that he or she will not experience any electrical shock during the test, and that the source of the electrical energy is the client's neural activity within the brain. Withhold sedatives, coffee, tea, and soft drinks that contain caffeine for at least 8 hours before the test to avoid affecting the diagnostic findings. Allow the client to eat. A low blood glucose level can alter the EEG. Direct the client to shampoo his or her hair to remove oil and hair products. Clean hair facilitates and promotes maintenance of electrode attachment throughout the test. Awaken the client around midnight before the EEG to ensure sleep deprivation. After the EEG is complete, the client who is sleep deprived can rest and have their hair shampooed to remove the glue used to affix the electrodes to the scalp. The nurse is assisting the client to prepare for a lumbar puncture. Which of the following actions should the nurse take first? Administer enemas until clear, remove all metal jewelry, position the client on his or her side, or remove the client's denture. The answer is position the client on his or her side. The client is positioned on his or her side to expose the spinal column for puncture. Neurologic testing. Nursing diagnosis is knowledge deficit related to unfamiliarity with diagnostic testing processes. Describe the procedure and preparation for diagnostic test. Inform the client of discomfort from procedure. Diagnosis also is meningeal irritation or CNS changes. Observe for neurologic abnormalities or diminished LOC. Report headache or sudden pain. Position the client flat for 3 hours after lumbar puncture. Also, we're going to discuss brain scans. A brain scan identifies tumors, hematomas, or in around the brain, cerebral abscesses, cerebral infarctions, or displayed ventricles. A radioactive material is injected before the procedure. The length of this procedure varies from a few minutes to 1 hour. CT scans and MRI are replacing this procedure. Electromyography, EMG, studies the changes in the electrical potential of muscles and the nerves supplying the muscles. And EMG is useful in determining the presence of neuromuscular disorders. Needle electrodes are placed into one or more skeletal muscles and the results recorded on an oscilloscope. Pain may occur at needle insertion sites and muscle soreness may last for some time afterward. Nerve conduction studies. Nerve conduction studies are performed by applying surface electrodes to the skin over locations of various nerves. When a mild electrical stimulus is administered, the speed with which the nerve impulse travels along the peripheral nerve is measured. These tests, which may be combined with EMG, aid in the diagnosis of nerve injury and compression or neurologic disorders affecting peripheral nerves such as carpal tunnel syndrome and the peripheral neuropathy experienced by clients with diabetes. Echoencephalography is an ultrasound examination of structures of the brain. This procedure is performed to detect abnormalities in the ventricles and the location of intracranial bleeding. And this is the end of the slideshow.